مسموع؟
تمام، صوتك مسموع بتول.
تمام، ممتاز. Hello everyone, this is Batul Sultana and it's a pleasure to be here with you today. I'm a pharmacist currently pursuing a master's degree in human nutrition with a specialization from the University of Glasgow in Scotland, UK. At the moment, I'm conducting research with SRA. Additionally, I serve as the team leader of the media team and the associate program director of the program RBB. Today, I have the privilege of being here with one of our valued partners, the Uplifting Syrian Women Organization. Please, Ms. Hajar, feel free to introduce yourself and your organization. Ms. Hajar, are you with us? Mm. I think she have a problem with her internet, so no problem. Also, I would like to take the opportunity to express my gratitude to Hakimak Dalilak, our media partner, for their invaluable support. Additionally, I extend my heartfelt thanks to Dr. Ibrahim Antoun and Professor Zakkar for being with us today. It's truly an honor. If you would like to share a few words, please feel free to do so. Dr. Ibrahim or Dr. Zakkar.
Thank you very much, Batul. Maybe I will start. I will speak a couple of things in Arabic and then I'll speak in English. طبعا مرة تانية يعني أنا كتير شاكر لكل الجهود اللي عملتوها، لكل الجهود تبع الفريق تبعك جميل وكل البارتنرز الموجودين معنا، لأنه هي great opportunity مثل ما حكينا المرة الماضية لنحاول نطور البحث العلمي ونطور الطريقة اللي بنعمل فيها البحوث بسوريا. ويعني أنا كتير ممتن لريكاردو إنه موجود معنا اليوم. ريكاردو كان واحد من المتدربين عندي بجراحة القلب، وحاليا هو سينيور ريسيرش فيلو بيشتغل بين امبيريال كولج لندن وبين يونيفرسيتي اوف ليستر. ريكاردو ما بس بيعمل ميتا اناليسيز، ريكاردو عنده بحوث علميه، بيشتغل بشكل اساسي على امهات الدم وعلى التورمات الابهار، وواحد من الناس اللي كتير عقليه علميه مهمه. بقى شكرا كثير لحضوركم وشكرا كثير لكل الموجودين، وإن شاء الله بتستفيدوا من السيشن. Just to say in English, I am really very grateful for Ricardo for being here today. I mentioned this in Arabic, but I'll just mention it again for him in English. Ricardo used to be one of my trainees in Leicester, and he is now a senior research fellow working between Imperial College London and the University of Leicester. He's always been an outstanding researcher. He did his PhD in Leicester, and among his many skills is really conducting world-class, very high-class type of meta-analysis. And I'm sure we all gonna benefit today. Definitely I will benefit from his talk, and I hope you all will benefit from his talk. So in advance, thank you very much, Ricardo, for coming to give us a talk today. And I will pass it to Ibrahim now to say some words.
مرحبا يا شباب، شو أخباركم؟ بنرحب فيكم بالمحاضرة الثانية. المحاضرة الأولى كانت نوعا ما كلينيكال، هاي محاضرة مور ريسيرش. ريكاردو كثير معروف بالميتا أناليسيس، اشتغل معنا فترة بلستر وهلا انتقل على لندن. فكثير رح تستفيدوا مثل ما قال بروف. أنا صراحة كثير رح استفاد لأنه عم بشتغل لحالي بموضوع الميتا أناليسيس. أنا كثير مبسوط إنه في كثير منكم تواصل معي على الإيميل أو على السوشيال ميديا مشان يشتركوا بالريسيرش، وأنا more than happy to support. وإن شاء الله هلا بعد ما ريكاردو يعطيكم محاضرة ميتا أناليسيس hopefully كثير منكم بلشوا بروجكتس ونشتغل كلياتنا مع بعض. فإن شاء الله تستفادوا منا ومستعدين نجاوب أو نترجم أو أي شيء بيلزمكم. نحن رح نكون متواجدين ضمن الجلسة. وشكرا. we'll hand it back لبتول أو ريكاردو.
بتول، ممكن بس قبل ما نبدأ، شفت حاليا انضم إلينا البروفيسور محمد سعد السليمان. بروفيسور سليمان، شكرا كثير لانضمامك لنا. بروفيسور سليمان هو الأب الروحي إلي بطريقة أو بأخرى. بروفيسور هو واحد من يعني أكثر العالم supportive research، هي واحد من أكثر العالم اللي بيساعدوا ودائما موجود لأي مساعدة. وكان يعني ولساته لهلا من العالم المهمين اللي أنا بروح وبسألهم وبحكي معهم طول الوقت. وعم نشتغل حاليا على إنه نعمل كذا مشروع بين بريطانيا وبين سوريا لنحاول نطور البحوث العلمية بسوريا ولنحاول نعمل مشاريع بحثية بسوريا. شكرا كثير بروفيسور كشلنا اليوم.
أهلا وسهلا فيك دكتور سليمان معنا اليوم. We will go back to the uplifting Syrian women with Miss Shaza Ali, and she wants to introduce herself and the organization. Please, Miss Shaza, go ahead.
Good evening, everyone. Can you hear me well?
Yeah.
Okay, thank you so much for having us. My name is Shaza Ali. I'm a co-founder and education and discussion teams manager at Uplifting Syrian Women. I'm going to give you a brief introduction of our initiative. It is a MENA award-winning initiative that uses digital tools to educate women and promote gender equality within the Syrian community. Uplifting Syrian Women provides a comprehensive support system offering virtual courses, career workshops, mentorship programs, psychological support, and legal consultations. These programs give low-income, vulnerable Syrian women the skills and resources they need to secure better jobs, heal from the trauma of war, and build a brighter future. Thank you so much for having us, and we're very delighted about this collaboration.
Thank you, Ms. Shaza. And I want to thank again Dr. Ibrahim and Professor Zakkar for their kind words and contributions. Finally, I would like to introduce the co-founder of our academy and the program director of RBB, Dr. Jamil Souqiya. Dr. Jamil, please go ahead.
Yeah, is my voice clear?
Yeah, go
Yeah.
ahead.
First of all, I want to welcome you all here in our RBB program, which we aim to bring valuable experience from outside Syria to our students. It is really our pleasure to have all of these professors and Dr. Ricardo and Professor Zakkar, Professor Sulaiman, and also Dr. Ibrahim. By the way, Dr. Ibrahim is just went out from the surgery. دكتور إبراهيم هلأ حاليا لسه طالع من العمليات. شفتوا لباسه انتو. And I would like to thank especially Dr. Ricardo for sharing with us his valuable experience in meta-analysis, and honestly for making this session, as it is truly needed and appreciated. I am Dr. Jamil Souqi from Damascus University and RBB Program Director in SRA with the 26 published research articles. I'm not going to talk too much and I will let Dr. Ricardo to introduce himself and start his session. So please go ahead, Dr. Ricardo.
Thank you very much, Jamil. Can you hear me?
Yeah, your voice
Yes, we can hear you.
Is great.
Perfect. I don't know what's the best way to share the slide. Can I share the slides myself or yes? Let me see. I can put up the screen. So let me start by saying how impressed I am by the initiative. I really want to congratulate Dr. Antoon, Dr. Sukia, all the organizing team, and of course I'm grateful to Professor Zakkar for inviting me. It is humbling to see the attendance to this event, and I'm really grateful for the opportunity to be talking to such an enthusiastic group. And more importantly, I'm talking about the topic that it's very dear to me. Meta-analysis are the way I approach the research world, and I think that for early career researchers, they are probably the best way to start a project, to get familiar with the research methodology, to start reading and documenting and build a successful practice from there on. I won't spend too much time talking about me. I'm a research fellow between Imperial and University of Leicester, and I'm a cardiothoracic surgeon when I find time. So this is probably what you want to get to when you think of a meta-analysis. You want to get to a forest plot. You know that there will be studies that you put together, and you get an estimate of the effect of the studies. And the way you get there, especially when you are not familiar with the type of the work, can be a bit mysterious, and it's not very easy to approach the topic. And the methods section are probably not the most approachable section of a meta-analysis paper. And what you want to see at the end of the day is what you should do in your clinical practice. So you want to get to the diamond at the end of the plot. What I'm going to tell you today is that you wouldn't start a recipe midway. So it's very important when you talk about meta-analysis to get to the result that you want to reach step by step. And the way this series of workshops is organized is particularly appropriate. So meta-analysis, are the apex of the pyramid of evidence. So you have your case report, you have then you have your observational studies in the middle. At the top, you get your RCT, and when you move more epically, the multi-center randomized controlled trial. But along with them, the evidence that it's used in the guidelines, it's corroborated, supported, it's made strengthened by meta-analysis, by systematic review, or more than one randomized controlled trial. And the medical community has certainly welcomed this type of publication of a research endeavor, like probably nothing else in the history of scientific literature. You can see that in the last 20 years, the growth of meta-analysis, this is just for cardiothoracic surgery, has grown exponentially, both meta-analysis and systematic review. And the reasons, besides the scientific value of it, might also be sought in the fact that meta-analysis are of a particular appeal to researchers. They offer advantages because you can basically access data there. It's usually publicly available, and you don't need extensive economic resources to perform a meta-analysis. And also time requirements. This is all relative, because I performed an analysis that took me 4 years to complete, but comparatively with the randomized controlled trial, it's quite a quick project to run. So what you will do when you plan a meta-analysis is go again step by step. Not all of these steps will be covered during this workshop, but they are as important as the things that we'll talk about. You'll have to identify your review question, you'll have to think about the eligibility criteria, you will have to perform careful study selection, then collect and gather your data, assess the risk of bias, and the comparisons that you are going to run need to be planned beforehand, before you get to do the statistics themselves. And I think that this will be mostly the topic of what my colleague, Dr. Layton, will talk about in our next workshop. And also there will be a very valuable talk from Dr. Fudulu that I very look forward to, that will deal with the statistics and the statistical analysis program. What I would suggest, everyone, I've been an editor for Cochrane Art for the last 3-4 years, and they are very valuable resources for young researchers. Besides the handbook for systematic review of intervention itself, which is very comprehensive, there are courses that are really helpful when you start trying to perform a systematic review, and they don't take long to complete. So this is a resource that's open to everyone, and it will be good to use it. So we know how important, we realize how important, how common they are, and what the advantage from meta-analysis is. But what exactly are we trying to achieve with meta-analysis, and why should we do it? So probably the most fascinating aspect of a meta-analysis is that you can identify a research question that's not been answered by the single individual trial, and you can come up with an answer that's still not available in the scientific literature. You can use the statistical instruments starting from data that someone else collected already, and reply to a question that no one answered before. The other point that you can try to do is, if you imagine a scenario where 2 big trials differ one from the other, you can resolve a controversy with a meta-analysis by pulling the data together and using also maybe smaller studies that didn't provide a robust enough answer to with the evidence. And lastly, another thing is that even in the presence of a general idea of what the effect estimate is, that you would get from multiple small trials, having a meta-analysis will make the estimate of effect more precise. So don't get scared about the formula. I won't have many of these, but just to start, what is a meta-analysis? It's a 2-stage process. So in the first instance, you get a summary statistic for each of the study. So you have a number that will summarize what the finding in terms of that comparison is for each of the individual trial. And then the second step is pulling together all these summary statistics to obtain an effect estimate. So this is a formula. This is the formula. It's basically a weighted average. So every estimate will have a weight that's usually depending on the sample size of the individual trial, and the effect estimate will depend therefore both on the estimate, so what effect was measured in the trial, and how powerful the trial was in providing it. So we get an effect estimate with this method. And what else will you see when you look at the results from a meta-analysis? You will see a confidence interval that will tell us how confident, how reliable that effect estimate is. And ultimately, although it's not encouraged, mostly in concurrent review, you get a p-value. So how certain are you from a statistical point of view that effect estimate is due to a clinical effect and not a random statistical a random chance. The other thing that you always need when you when you report the result from your meta-analysis, so effect estimate, a confidence interval, and lastly, an assessment of the variation among the results of the separate studies. Because it's not about, this is not a single trial, this is multiple trial. You get a sense of what the effect estimate is, you get a sense of how reliable it is, but you still have to communicate how much the trials differ between themselves, among themselves. And this is what's called heterogeneity. How do we look at this in the forest plot? This is an example from one of the meta-analyses I did quite recently. And we were looking at all the measures to reduce inflammation in cardiothoracic surgery. It was a massive work, and this was it was about one of the cytokines. But what I want to focus your attention is that at the end of the forest plot, you'll get an effect estimate, you'll get a confidence interval again, how reliable it is and whether it touches the line of no effect or not, and you can see that it doesn't here. And you get also a measure of the heterogeneity. That here was, in this case, was exceedingly high, and so we had to do something else about it. So to go step by step again, and follow our recipe, we start from producing the from obtaining the measurement from the single individual trials. They could be already reported in different ways. There could be two per two tables. There could be a mean plus standard deviation plus a sample size. In certain cases, you find a median. There's a way to convert it to mean standard deviation. In certain cases, you find odds ratio and relative risk already reported by the trial authors. The thing is, whatever you're trying to achieve, you have to convert this effect estimate into the same thing. So there's statistical method to do it. You can do the calculation by hand or with a calculator, and there's very convenient programs that you can use as well. I think the easiest one is probably RevMan. In its latest version, it's RevMan Web. So it's completely online. It's the tool that you use to perform Cochrane reviews. And you can enter the data directly on the browser. And at the end of it, it will automatically calculate the effect measures in the same way. What you will do after that is you have to specify what your meta-analysis method is. And we will talk about how we make that choice. So once you have all your effect measures from the individual trials, you have to pull them together with a meta-analysis method, and you will obtain the effect estimate. So how do we obtain the effect estimate again? We have to start from effect measures. So effect measures, there's different types. The most common one probably, and the easiest one that you can use when you want to convey a risk is probably the risk ratio. You'll find it mentioned as well as relative risk. Don't get confused. It's the same thing effectively, and it's clinically is the one that we use more commonly, and it's the one that you'll find Cochrane reviews encouraging to use relative risk when reporting their results. Odds ratio are an equally powerful way to report on the effect measure of an intervention, but they are a bit more difficult to use in the clinical practice. So gamblers and use them a lot, but clinicians are not very, they don't like them very much. Relative risk is much easier to find in a systematic review and in a meta-analysis. And the risk difference instead is not the most encouraged way to use as effect measure, but it's very useful when you want to produce a summary of finding, because it very quickly gives to mostly a patient an idea of what is the reduction in risk from adopting an intervention instead of a control group, or vice versa. For continuous data, instead, you'll have found this in your statistical courses. So there's mean difference, standardized mean difference. These are the most common ones. And it all depends on what kind of outcomes and how much they differ across the individual randomized control trials. So it's very important that you can't pull together studies with who have 0 events in terms of risk ratio and odds ratios, and there are some adjustments that you do in and that actually programs like Revman Web do for you automatically. They had a 0.5 to bot intervention control group, and we talked already about the risk of misinterpretation by using an odds ratio instead of risk ratio. It's very important to make your selection, how you want your studies effect measure to be reported, and try to stick with it, because it avoids confusion and misinterpretation. Risk ratio goes from 0 to 1. Odds ratio can go from 0 to an infinite value. So it needs to be very clear what kind of effect measures you are using. So as you will probably remember from the previous picture, so we talked about the effect measures, and to combine the effect measures together, you have to select a method. So the inverse variance is probably the most common one. The formula is above. Is basically every study is pulled together, and the importance of each study in the context of the pooled analysis is based on the inverse of the standard error. So how precise is the study? So you can consider that the larger the samples, to simplify things, the larger the sample size, the more that estimate from the single study will be precise. So in a fixed effect meta-analysis, the studies with a large sample size will have more importance because they are more precise. When you have sparse data with low events, when something is rare as a four-leaf clover here, you can do different kinds of fixed effect meta-analysis, the Mantel-Hansen method or the Pato fixed effect meta-analysis that works only for odds ratio, and in particular works very well when there are very rare events. But these are 3 methods that you would use when you have a fixed effect. What does it mean, fixed effect? When you can be certain that the effect across the different studies, the effect of the intervention is the same. And when can you do that? You will do that when the studies, the individual trials, have very comparable setting, population, type of intervention, and measurement of the outcome is similar. In those cases,
حابين تدخلوا على الميتينج عن طريقة الزوم، الكود عندكم متواجد على الشات، تفضلوا تفقدوا.
In those cases, fixed effect meta-analysis is very powerful and it's opportune. When instead you expect that there are some characteristics that will lead to the intervention working differently across the studies, So your population from the trial is not exactly the same, or there are different conditions that made the experiment different perhaps across the years, that the trials were from the past decades and there are more contemporary ones. Then you will have to adopt a different methods, which is the random effect meta-analysis. We will get back to this. What I wanted to talk about is something that when you first read a meta-analysis and when you first try to run a meta-analysis, probably you don't put too much importance in the heterogeneity, which is nonetheless a very important aspect. It's very peculiar to this type of research methodology, and also is an opportunity to gain further insights from the finding that you achieved, and this is something that we'll see together. So when you heterogeneity is essentially the variability among the studies in the systematic review. So there are different types of heterogeneity. There's the clinical diversity of the patients, or the intervention, or the outcomes measured. There's the methodological diversity, and this will be due to the study design adopted, the measurement tool that you use to assess that the investigators use to assess the outcomes, but also the risk of bias influence the methodological diversity, and these two things together contribute to what is the concept of statistical heterogeneity. So clinical variation by itself leads to the heterogeneity. In particular, if the intervention effects are affected by this varying factor that we were mentioning across the various studies. The methodological factors that I was mentioning, probably Giorgio will focus more on bias, but you can understand that if one study was very strict in the blinding of patients and participants, or in how they run the randomization procedures, or how in the way they defined the outcomes that they would measure, you can understand that probably the measurement of the effect won't be the same with another study that wasn't strict enough, and possibly the placebo effect was a factor in that other study. So the study will be different one from the other, even if they adopted the same intervention. What is a significant statistical heterogeneity? This depends on the definition that you put in your protocol, but usually around 75% is what a measure of I-squared that we would define as significant statistical heterogeneity. This having a very high heterogeneity value, it's dangerous, because it might mean that the direction of the effect does not indicate the true effect of the intervention, and the studies might be simply too different one from the other to pull together, like apples and oranges with the classical definition. So how far can we push ourselves by putting different studies together? How strict do we need to be able to compare apples to apples and apples to oranges? Well, the thing is, I showed you an example of all of a systematic review that I myself did when I put together all the studies done in cardiac surgery about inflammation. That was too broad, too wide. But the thing is, I could not answer the question I wanted to answer if I wasn't broad enough. So the inclusion of studies that differ a lot one from the other will be determined by the question, the clinical question that you have. So, and that will, of course, determine the scope of your review. So it's an advantage of the meta-analysis itself. Meta-analysis, by definition, can take a broader perspective than a single clinical trial. And of course, you can be comparing a drug to the other, or from a single class of drugs, or you could be comparing two different classes of drugs, and those will be two different types of meta-analysis. How do we measure it from a statistical point of view? Again, this is not the workshop in which we talk a lot about statistics, but just to give you an idea of the things that you will find a chi-squared test very often. In this case, the p-value that you use for statistical significance is 0.10. But the most common way to convey what the heterogeneity in the meta-analysis was is probably I-squared statistics. You will I showed it to you in the first forest plot that I put in the presentation, and you can see there are different classes that different ranges of figures of I-squared that define statistic and the statistic interpretation of the I-squared. So from 0 to 40 is not that important. Moderate heterogeneity from 30 to 60, 50 to 90 substantial, considerable from 75 to 100. As with everything that I kept repeating throughout these slides, these are numbers, these are statistics. The findings and the message from the meta-analysis will be based on your clinical judgment. So that's why they overlap partially. What do we do if we did a lot of work in the past 4 or 5 months? We put the studies together. We were very robust in our assessment, and lots of nights spent on data collection. And then we realized that our I-square is 85%. So we need to do something about it. We cannot just ignore. The first thing that you have to do is that your data were correct. It's very common that a comma was not in the right place, and this introduced a massive heterogeneity because now one of the trial looks so different from the others. So first thing, it's very basic, but check the data again, because it's always happened to me. It keeps on happening. So there's nothing wrong. That's why we double check our work. One possibility, if you realize that heterogeneity is so high, it means that you really are comparing apple to oranges, and giving any sort of judgment on the direction of the effect might be misleading. You might be saying something that is far from the truth, that doesn't correlate to something that it's meaningful in a clinical setting, and that might confuse both your colleagues and the patient if they come to read about it. So you might want not to meta-analyze in that case. What you can do is still do your systematic review and provide a summary of the individual studies, but not a common effect estimate. And then, of course, there's the possibility of exploring the heterogeneity. So there's different methods that we'll look at individually. The commonest one are the subgroup analysis and the meta-regression. And as with randomized controlled trials, if you look at something long enough, if you keep repeating experiments, you're going to find something. You're going to find something, if anything, by random luck, by chance. So the basic principles, one of the basic principles in research is that you come up with a question and you determine before starting what your methods will be. And this applies to meta-analysis as well, and to the investigation of heterogeneity. So if you plan subgroup analysis and meta-regression, you have to plan this before you find your heterogeneity, and before you have to do that. So if you think that in this group of trial, you have 3 studies that were conducted in mostly young patients, and other 2 studies were conducted in elderly patients, before you get to the meta-analysis, before you start analyzing the data, you might want to plan and write in the protocol that you will do a subgroup analysis based on age, because age might be one of the factors that will influence the direction of the effect across the studies. So random effects meta-analysis, as we were mentioning before, their assumption is that the intervention varies across the studies. So in some way, a random effect meta-analysis already incorporates the unexplained heterogeneity. So it's statistical method of analyzing different individual trials, in which we know as clinicians that this intervention, it's bound to have different effects across the different trials. We say from the beginning that there will be heterogeneity across the trials, and we use the pooling method that takes account of it. Nonetheless, you see that it's not exactly as meaningful as investigating the source of heterogeneity. So it's not a substitute for a thorough investigation. So you have to be robust in your planning and in explaining why you're going to adopt this method of analysis. Sometimes the effect measure itself can, because there's method to convert from one to the other, can create heterogeneity. Also, there's a possibility to convert from continuous to dichotomous outcomes, and this can introduce some heterogeneity. So it wasn't in the trial originally. The trial were reporting the same effect but in a different way. But when we tried to make all apples and oranges all oranges, we introduced the heterogeneity ourselves. Lastly, you might realize that it's one of the studies that is causing really an issue to you, and it's not unreasonable to exclude studies, and you will have to justify why you're doing it, and you will show to the reader that this is your sensitivity analysis. So you'll argument that this is what I see with this study, this is what I see without this study, and this is why we think that this study doesn't really apply, it's not really meaningful, and it's not really comparable with the others. So just to focus a little bit on the random effects model, we already talked about this, and we don't need to go too much into the details, because I want to go a little bit into the more practical section of the presentation. So the random effects assumes that that the studies estimate are different, but because the intervention effects across the study are similar, but again different from each other. And it incorporates the unexplained heterogeneity across the studies. You adjust the standard errors to account for the heterogeneity, and this variation is called tau squared. What matters probably from a practical point of view is that when you do a random effects meta-analysis, again, it's very meaningful when the studies differ a lot from each other. But what you will do, you remember the fixed effect meta-analysis was giving more importance to the studies that were more precise. This won't be the same with the random effects meta-analysis. So yes, the larger sample sizes will still carry more weight in the final analysis, but comparatively, smaller studies in the fixed effect meta-analysis carry bigger. Smaller study carry more weight in the random effects meta-analysis. So again, you exploring heterogeneity is probably a bit more meaningful when you want to inform your reader and to get to the bottom of the question. But still, in some cases, you can't do anything else but adopt a random effect model. So how do we choose between one and the other? So the fixed effect meta-analysis, once again, just to summarize, you have a typical intervention effect. You assume that the true effect is the same, and every difference is due to chance. In the random effects, you have an average intervention effect. You assume that the effect follows a normal distribution, and the differences are due to chance and also to genuine variation. We talked about the in between trials differences. So if we compare the two formula, you would realize that if there is no heterogeneity, basically the results from a fixed effect meta-analysis and a random effect meta-analysis would be identical. And the impact of bias, the bias will be exacerbated in a random effect meta-analysis from smaller studies because they have more importance. And unfortunately, smaller studies are the one usually the less methodologically robust. And this could be a problem about the reliability that you will have from a random effects meta-analysis. So there is no universal recommendation whether to choose one model or the other model. So you'll have to make effectively a clinical judgment here. You can do a consideration of the heterogeneity to choose one model against the others. You can look at the plot that probably will be touched in the next workshop, which is the funnel plot. But from a pragmatic point of view, probably the thing that I tend to do more often is to do both. You can do a fixed effect and a random effect meta-analysis, and don't be scared. I know it's a lot of work to do a meta-analysis, but actually in programs, in software like Redman or even R that Dr. Fudulo will talk to you about, changing between one model and the other is a difference. You do it with a click, basically. So as long as you plan what you're going to do, the tedious part of it is going to be looking at the study, extracting the data, and putting the data in. But writing the methods, you'll have to do it with your clinical mind and not only with your statistician mind. And now the funny bit of heterogeneity and the things where you might find yourself finding something new that wasn't discussed in the individual trials is assessing the interactions. So when you find an heterogeneity value that you said you would try to understand why the studies differ so much from each other, you have an opportunity to understand what is causing this variation. And there's two methods again to adopt here. You can do subgroup analysis or you can do meta-regression. Subgroup analysis basically are a way to split the patient into different subgroups. And you compare the subgroups with each other. So you do small separate pooled trials, and you see if the heterogeneity in trials conducted before 2010 and trials conducted after 2010 are different. If you have lower heterogeneity in any of this group, you might understand that it was the difference between the trial themselves, that the age in which the period in which the trial were conducted, that caused the trials to be so different one from the other. There's two types of interaction. There's the qualitative interaction, which is basically every subgroup reverses the effect, the direction of the effect. And the most likely one is the quantitative interaction. So an intervention still works or still doesn't work. It just doesn't work as much across the different subgroups. So it's very important that from a statistical point of view, doing a subgroup analysis is still some form of post-hoc analysis. So in a randomized controlled trial, if you go back at the trial and you look only at a certain group of patients, what you lose is the randomization. So what makes the randomized controlled trial so powerful is that the random chance of one patient being allocated to a group instead of the other makes the two groups really comparable in terms of baseline characteristics. If you choose to select only one group from the randomized controlled trial, you're looking at a specific set in which the patients are not really randomized in the same way, and the baseline characteristics might differ. And this is the same thing with meta-analysis. So if you do subgroups of the studies, you lose the same meaning of the initial comparison. So still, nonetheless, it's a useful way to investigate the heterogeneity, and you can have an heterogeneity value across the different subgroups, and a total heterogeneity value for the subgroup differences. Meta-regression is a bit more advanced, but to do it, to simplify it the best we can, when you have subgroup analysis, you are comparing group A, group B, group C based on categorical characteristics. Meta-regression uses continuous outcomes. So I want to see if age was a factor that influenced the direction of the effect. So if I split the two trials in trials conducted in patients below 60 and trials conducted in patients above 60, what I'm doing is a subgroup analysis. If instead I consider age as a continuous outcome, and this can be usually done with a kind of information that we get from the trial publication, what we conduct is a meta-regression. It's very simple it's very similar to the simple regression. You get an effect estimate, and you get a regression coefficient. And what you do, you test for the linear relationship between the intervention effect and the explanatory variable that you hypothesize. In our example, it was the age. So just to show something in practice, this is the last one that I did. I still have nightmares about it. This is a Cochrane review about the use of prophylactic corticosteroids in cardiopulmonary bypass. Luckily, Prof Zakkar helped me with this. This is very comprehensive, and it was done in all the trials that were conducted in adult cardiac surgery. And you can see the way I started it is with a PICO. PICO stands for Population Intervention Comparison Outcome. This is the basics for all the research projects you do, comparing an intervention with a control group. And this is where I encourage you to start from even also for meta-analysis. You have your screening and your sets of studies included. This is all something that Georgia will explain in much more detail than I will do now. But you basically have to look at the characteristics of the individual trials to assess how much of bias, how much the characteristics of how the experiments were conducted influenced the results from the trial itself. And what you end up at the end of a systematic review is this table. It's called a summary of finding, and this is what I was mentioning before. You see, the way most clinicians will use this table is with a relative risk, but what Cochrane wants and what would be good practice is also to put it in terms where the patient can understand. So they putting numbers, every 1,000 patients, 33 would have this risk versus 30 would have this risk with intervention of the control group, gives a very quick way for the patient to imagine what the weight of the intervention is. This is one of the forest plot from the review. This is what we were talking about. You can see every study will have an estimate, confidence interval, and you can see how big this trial is. This is Professor Whitlock's trial from 2015, and you can see that comparing this trial with the others, they had so many more events, both in the intervention and in the control group. Also, they were. This was a very large study, and the weight they carry in the meta-analysis is much bigger compared to the other studies. Also, from a methodological point of view, it was flawless. You can see how this traffic light plot is all green. Nonetheless, the studies were pretty much similar between themselves, and the I-squared value was 0. You can see that at the end of this forest plot, despite the massive work, what I could conclude that in terms of mortality, there was no difference between the steroids and the control group. But when I looked at the cardiac complication, again, Professor Whitlock's study was the most meaningful one. I could see that in when using corticosteroids, there was a bit of an increased risk of cardiac complication. This was something that, of course, you were not expecting to find, but it was in the original trial, where it wasn't completely significant, but actually it was significant. But you can see that the meta-analysis increases the confidence in the results because it puts it together with other studies that differed in the effect estimate. So when you look only at Whitlock trial, there might be something that that makes you think, was it something that was due to the study itself? In this specific situation, we had to think about it, and in the conclusion, we said that we need to be careful how we interpret this finding anyway. Even though from a statistical point of view, you would say yes, corticosteroids can cause an increase in cardiac complication. From a methodological point of view, you have to think.
Ricardo?
Yes.
Hi. Just, I think someone is asking why shouldn't Whitlock, in this case, be excluded given the vast difference in event numbers? I'd rather ask this question now, because if we ask it later on, it won't be as useful. So would you mind commenting on this, please, for the audience?
Yes. So that's a good question, and a potential approach to this to this analysis would have been to exclude a trial, but to do that, you have to give a justification, saying that we exclude Whitlock based on the fact that the results are different. would ignore the fact that this trial was done in more than 7,000 patients, when most of the other trials had a sample size of around 100 patients. So it's true, it skewed the result, but it's the methodologically more robust trial, and we cannot simply ignore the directional effect that it proposed. It's a bit more complex because it carries a bit more work, but it's the more appropriate thing to do is to understand why Whitlock's results were so different, keeping it in the analysis, but understanding why the results were so different. And the reason is that the type of measurement that they adopted from cardiac complications were different from the ones that were adopted in the other studies. So there is an heterogeneity. There is not that you cannot view in the statistics, and this is why I'm telling you, not about just numbers, but the clinical reasoning that you do. So what you can do in this case is you still have to present this forest plot because you don't have a strong reason to exclude the most powerful trial that was done in this field of research, but you caution the reader, and when you present the finding, you lower the certainty that you have in the results, because you tell them it depends on the definition that you adopt of cardiac complication. If you use an omnicomprehensive definition, yes, it's true, there might be an increased risk of corticosteroids, but if you adopt a more specific definition, well, in that case, it depends. So, but it's a very good question, yeah. And to look at an example instead where we had a very high heterogeneity value, this is looking at the ITU length of stay across the different trials. And you can see how corticosteroids seem to reduce the length of stay in ITU. This is in hours, so 6 hours less in ITU. But the I-square value is 86%, which is very high. So what you can do is what we did is that we already said that if we had found ourselves with a value of considerable heterogeneity, we would have done a subgroup analysis based on the type of surgery performed, on the quantity and the type of corticosteroid. We would have done meta-regression based on age. I want to show you this subgroup analysis in particular, because you can what you can appreciate is that there is a difference between the groups of patients in which the intervention was applied. So the CABG patient, the BAV patient, and there's trials in which there was a mixed population. And you can see that the ones that probably determined mostly the direction of effect are the trials conducted in a BAV population, which is just 2 studies from the same authors. So from a methodological statistical point of view, there's not a lot of heterogeneity. There's a direction of effect. We can do a comparison with the other interventions, and we could say that there is a difference. So you might be tempted to say that in VAV patients, there's the corticosteroids reduce the ITU length of stay, but I think, and this is something that you might argue against, it's probably not the most appropriate thing to do. And again, you need to caution the reader, because over-interpreting the data based on 2 studies with 30 patients might be dangerous and misleading. So you have to show the results, but the comments and how you interpret the results, always be cautious how you do it. don't deliver strong messages. And this is the last thing, is a meta regression. So we investigated the risk of cardiac complication, mortality. These are the main outcomes, but we did it also for the secondary outcome based on continuous factors such as publication year, age, BMI, and you can see that basically there was nothing that explained the heterogeneity in these outcomes. So sometimes you are disappointed. You have some interesting findings, like the one for cardiac complication was another one that they reduced the risk of respiratory complication instead. And you can convey a very useful message, but don't be hyperbolic in the terms that you use. Lastly, just to show how meta regression can be conveyed. Meta regression is is basically a linear regression. So you can show a regression coefficient and moderator, or you can basically draw a regression line. And these when you see these plots, these circles are the trials. The regression coefficient is represented by the line, the confidence interval with a shadow around the line, and the dimension of the circle itself, it's the sample size of the trial. So with that, I finish, and my best wishes to you all to reach that diamond. And it's a lot of work, but it's worth it.
Thank you very much, Dr. Ricardo. And we have many questions. The first question is there a bare minimum number of studies that needs to be met in order to qualify to formulate a meta-analysis?
Yes, that's a very good question. So there are suggestion and recommendation, and the most stringent ones are the ones when you perform subgroup analysis and meta regression, and the limit in that case should be 10 studies. That being said, pooling studies together can always be useful if you think that they are similar enough. Just don't use meta regression for less than 10 studies, because that's not going to give you any reliable conclusion.
Wow. Okay. What's better to show our research ability and better for our CV? Original research, like a cross-sectional or cohort studies, or meta-analysis?
So my advice would be to do both. So whenever you want to embark on a research project, the very first step should be to do a systematic review of the literature. You'll get comfortable with the topic. You get information about what the others did. You get a good overview of what the methods and conclusions have been, and once you get trials themselves, it doesn't hurt to have to produce a good paper by meta-analyzing the individual studies. You can do it both for randomized controlled trial, but also for observational evidence. And this doesn't exclude the fact that in the meantime, you are learning enough to write your protocol and do your cohort study.
Another question, in the case of comparing two drugs that do not belong to the same group, does it lack clinical significance if they have a common aim or therapeutic use? For example, as the comparison between beta blockers and calcium channel blockers regarding their effects on blood pressure, wouldn't it still be valid?
It's a very good question, and it's something that it's a problem that I encountered myself when I was doing the systematic review on all the anti-inflammation strategy for cardiac surgery. It might not be as meaningful as comparing to drugs from the same class, but it's still an important comparison to make. And if from your clinical point of view, what you want to do is comparing two different classes of drugs, then you should do it. With you realize that there will be at the individual trials level differences, for instance, in the reason why that drug was prescribed or in the population in which that applied. I don't know. You can find a trial of beta blocker medication conducted in Marfan patients. It's an excellent trial. It guides our practice for the management of thoracic aneurysm in Marfan patients, but it's done in a very specific subset of patients. And calcium antagonists, instead, you can find the trial conducted in post-CABG patients that use calcium antagonists for the patency of the radial graft. So they are so different one from the other, and you might find yourself in the position where you have to include both of these trials in your analysis, and you're comparing effectively apples to oranges in this case. So you have to, if you want to do that, you write a protocol in which you say that you are comparing these two drugs in a similar population, and you write your inclusion criteria in a way that you'll only identify this types of trial in which the drugs are used only as an antihypertensive medication in a patient for general cardiovascular health prevention.
Thank you very much. Another question. Using the fixed effect means we assume the difference in estimates is solely due to sampling error, a condition that's rarely the case. So do you believe it's better to often go with random effects?
I think in the clinical, in the field of medicine, very often we'll end up using a random effect. I very rarely use something different than the random effect model. That being said, if you are strict enough with your inclusion criteria, you might be in a position to use the fixed effect, which, as we said, carries a lower risk of getting biased by smaller studies.
Batul, can I just come in here?
Because sure.
I was going to say the same thing, and probably Ricardo will agree. I think it is probably useful when you're doing this kind of work to run both of them. So you do the fixed and you do the random effect. And you can always present both of them and publish both of them in the same paper. So some of them can go into supplementary data, some of them in the main data. But I think it is very useful, and it actually looks good on the publication, and it looks good for the reviewer to have both of them. Am I correct?
Yes, definitely. As I was saying during the presentation, it doesn't take long to do both. So the hardest job is getting the data run. Once you run the analysis, it's not difficult to convert from one to the other.
الشغلة الثانية اللي بدي أقولها أحكيها بالعربي مشان الشباب والصبايا يفهموا علينا شوي. هي لما بتشوف البرزنتيشن وبتشوف الشغل بتفكريها كتير معقدة، بس هي بالنهاية ما أنا معقدة نهائيا. هي الأهم خطوة والخطوة الوحيدة الأساسية اللي لازم أي حدا بده يعمل هذا البحث إنه يعملها هو جمع المعلومات. لما بتجمعوا المعلومات وبتحطوها على الإكسل شيت، كله هذا الشغل ما حتعملوه انتم بايديكم، السوفت وير كلياته بيعمله هو. حتى مثل ما قال ريكاردو، اذا بدك تعمل فيكست افكت وراندوم افكت، اتس ليترالي انك تكبسي زر ثاني غير الزر الاولاني. يعني الشغل كله هذا على السوفت وير. اهم شيء هي جمع المعلومات، collecting the data.
Ricardo, can I ask a question, please? Can I jump in quickly? I think someone asked a very good question. I kind of agree with them. So at what time do you consider doing an updated meta-analysis? Let's say you're interested in a topic and you see that the same meta-analysis was done, let's say 5 years ago. When do you consider repeating the meta-analysis? I thought that's a very good question.
That's a very good one. According to Cochrane standards, they usually invite authors to repeat the meta-analysis I think that 10 years after the previous one, which is a long time, but this is for Cochrane reviews. The other reason that you would for which you would repeat a meta-analysis is whether you think you identify a flow in the previous one that was conducted, or if you are interested in an outcome that wasn't assessed in the previous systematic review. And lastly, the thing that might lead you to repeat a systematic review is whether there is new evidence. This I will certainly have to repeat the one on the corticosteroids, so I encourage any of you to do it in my place, because that would be welcome. I'm not really keen on redoing it once the new trial from Wicklow comes out.
بشكل عام على ما أظن إنه 5 سنين فترة منيحة، بس إذا مثلا خلال فترة معينة خلال سنة أو سنتين فجأة طلع 5-6 randomized trials جديدة, it will be very sensible to repeat it.
For example, if there's a signature trial, New England paper or something big, you can always consider redoing it, I think.
Absolutely.
Batul, any more questions?
Yeah. Another question. Is it better to do a RE meta-analysis or rather two subgroup meta-analysis and then find the relationship between these two?
I think I will stand with what Professor Zakkar said here. I think it's good to be both. I think subgroup analyses are a very appealing concept, and they push you to think critically about your data, and it's very useful to include them because they are also appealing to the reader and to the journal. But again, doing fixed effect and random effect in the same publication, it's certainly feasible and doesn't take long.
Thanks. Is there any final formula to calculate all of these effect measures, no matter what they are?
Sorry?
Is there any final formula to calculate all of these effect measures, no matter what they are?
There's lots. There's lots. So the thing is, there are several formula, and you might the more meta-analysis you do, the more you get familiar with the different methods, especially with continuous outcomes. They are reported in a lot of different ways. You find median and interquartile range. You find median, upper limit and lower limits. But you need to compare. Sometimes you find geometric mean. So they are presenting them in a very there's lots of way to measure it. Rethman, the Cochrane tool, offers a way to convert one to the other, and there's a list of formula in the Cochrane handbook as well to convert, especially the median to the mean.
Okay. Are there any ethical consideration when conducting and reporting meta-analysis? How can we ensure transparency and the responsible dissemination of findings?
This is a very, very, very good question.
Good question.
This is a very, very good question. And that's, when I was stressing, don't be hyperbolic in your in how you report your findings. This is exactly what I was thinking about. If you, the first thing, it's about how you plan the meta-analysis. So about conducting the meta-analysis, you have to publish your protocol, or not publish, but you have to make your protocol available before you start your investigations. There's two ways to make this available. The easiest one is to use Prospero, which is a database of systematic reviews protocol that was managed by the University of York, and it's free to use. It's a very quick process. They have a template. You fill it in with your inclusion criteria, the reason why you want to do it, the methods that you're going to use. They do a very quick review of your protocol, and then it's available to everyone online. The good thing about Prospero is that allows you to check if on the database someone is doing something very similar to you, and or if it's already completed, and it makes you understand whether you should go ahead and continue, or you need to differ in some way. So first thing, when conducting, to ensure transparency, make sure that your protocol is going to guide your practice and is going to make what you do transparent. Responsible dissemination. This is what I was mentioning before. A protocol keeps you on track. Keeping on digging into the same data in order to find a p-value that satisfies you is malpractice. It's a research malpractice. Instead, if you do an analysis plan and you say that this is what you're going to do, and if you, as a clinician, have concerns about the validity of what you found, be measured in the language that you use. It won't go on the New England. Maybe if you don't have a finding that that is as resonant as you wish it to be, but still you be sure that you are having proper research ethics, and that that research won't harm patient and won't misguide your colleagues.
There is one extra point. There is difference between statistical significance and clinical significance. And you have to be very careful when you're writing a paper and you just say, oh, significant, statistically, whatever. You have to be careful because it may not mean anything in clinical practice. And that's why even if you're writing meta-analysis or systematic review, everything, I always encourage everyone in the discussion to discuss the papers and to talk about these papers, what their data showed, what do we think about them? Because there are some papers who will use the 0.05 for everything, and then you will end up in a big journal, but this won't mean anything. You have to be really careful, and you have to put it from clinical perspective, because by the end of the day, all of us are doctors, and this is something that will affect practice.
That's very true. And on this topic, when I wrote my first draft for the Cochrane review, the first thing that they told me, remove every wording that resembles statistical significance. They don't care. They don't want you to write this is statistical significant, because this is not what matters to clinicians and to patients.
I have two more questions. The first one, doesn't it require 20% larger sample size to do an updated meta-analysis? Also, when should we show publication bias in a meta-analysis? I have found no consequence on the topic. Usually I do it if there are larger, more than 10 studies included in the analysis.
Yeah. So what you're thinking of is the Egger's test for Farmer's plot asymmetry for publication bias, and that's true. That can be done with 10 studies. So I think that probably Daniel or Georgia will talk about bias, so publication bias. I'll left it for them. What was the beginning of the question as well?
The beginning, doesn't it require 20% larger sample size to do an updated meta-analysis?
Updated meta-analysis should be done with a larger sample size. It's not worth it to do in a smaller set of studies. If you have a very interesting question and it's different from what is published, you can limit your search to a smaller set of studies, but it's not going to be welcome. The peer reviewer will say, why should we look at this one? Last year, there was this other bigger systematic.
Ricardo, I think Batul's question is about updating or doing a new meta-analysis. So is there a requirement for you to, if you want to do an updated or another meta-analysis, to have 20% more in terms of the size of the population, or it does not matter? I don't think it matters.
No, I'm not aware of a specific figure, as long as you justify it from a clinical point of view. Yeah.
Ricardo, how far do you go back in terms of studies? Like, do you the last 10 years, 20 years, 25 years, how far do you go back? Professor Zakkar, if you know as well.
Cochrane would tell you from the inception of the medical database to contemporary practice, but I always end up arguing with them. I think that if you have a good reason to show that studies before a certain period are not relevant to current medical practice anymore, you have a reason to include a period criteria in your screening process.
And I have the last question, also about the updated meta-analysis. Do we have to do it from scratch, or we can rather reference to the previous meta-analysis and just add the new studies?
So there's different ways of doing it, and you can use the data from the previous meta-analysis, but you should double check. So sometimes you have errors, and what you end up is propagating the error from the previous meta-analysis. So as long as you are honest, transparent in what you do, both approaches are justifiable. If you start from a meta-analysis of 300 randomized controlled trials and you want to update it to the contemporary last 5 years of practice, it's unreasonable to go through the 300 studies again. But as long as you specify what you do and what your approach was, no one is going to question it.
The other important point is that really what you are doing here is you are taking the hard work of someone who's done it before you and just adding one or two things on it and publishing it. Ethically, you need really to get in contact with the team who published, let's say, the original meta-analysis, offer collaboration. You know, they can send you the raw data. We usually in academia tend to collaborate a lot. So if you email them, say, listen, I'm interested in doing updated, I'm going to include most of the stuff that you've done before with the new data, they will help you and send you the raw data. So you don't even have to kind of spend time doing the raw data. But you need really to think about it from the term of ethics and you know, contribute. So get other people who did it before to be on board with you.
Okay, I have another last question. I'm sorry, but the students like the session too much. It's an interesting question. Can we use an AI in meta-analysis, and how, and what is your advice?
Well, the student like the session. I'm liking the questions, and it's a very good one. And there's lots of initiatives that they are trying to use AI to streamline the systematic review process. At the moment, the most useful subsetting in which AI comes into play, it's the screening. So the screening where you have a huge list of trials with your abstract, and you have to go through 6,000 abstract. AI can help in that. If you define the criteria that you want to use for study inclusion, you try always to be a bit broad with your study, so you get a lot. If properly trained, AI can filter to the abstract, and when you get to the full text screening, you probably need to put the attention yourself, because you need to read the paper and extract the data. But for the screening of the abstract, that's a field in which I'm seeing lots of efforts to start using AI.
Okay, finally, I would like to take a moment to sincerely thank you, Dr. Ricardo, for everything, for being here with us today. It was a very interesting session. Your presence is incredibly valuable to us and to the Syrian students, and we truly appreciate it. Again, a heartfelt thank you also goes to Professor Mustafa Zakkar and to Dr. Ibrahim for their continuous support and contributions. Additionally, I want to thank Dr. Um, One second, I forget. Sorry, Professor Sulaiman, for his presence today here with us. Yeah, and I want to also thank our partners, Uplifting Syrian Women's and Hakima Dalilak. Finally, thank you to everyone who joined us today. We look forward to seeing you at the third session on the 29th of January. Stay updated on news regarding times and places by following us on Facebook, Instagram, LinkedIn, and Telegram. Thank you all once again, and goodbye.